You know, when you think about the human body's largest organ, your mind probably doesn't go to the liver or the brain.
Right.
It is, of course, the skin, the whole integumentary system.
Hmm.
And in the world of pediatrics, I mean, the skin isn't just a covering, it's constantly telling us this really complex story.
It's a narrative.
Exactly.
Right.
It ranges from something incredibly common and manageable, like, a diaper rash, all the way to a life-threatening emergency, like a severe burn.
Absolutely.
So for anyone who's focused on Canadian maternal child nursing practice, mastering that story, really understanding the language of a dermatological assessment, it's non-negotiable for safe and effective care.
And that's really our mission for today. We are taking a deep dive into Chapter 52, focusing specifically on integumentary conditions.
Okay.
And our goal is, I think, comprehensive mastery. We need to move beyond just, a superficial look.
Right, just looking at a rash.
Exactly. We need to really understand the sophisticated layers of this system. We're going to be synthesizing the terminology, getting a grasp on the underlying pathophysiology of common pediatric conditions, and then applying those critical evidence-based nursing interventions that are required in a Canadian healthcare setting.
And everything we're discussing is pulled directly from Perry's maternal child nursing care in Canada.
That's right. So this is immediately high-value, applicable knowledge for anyone listening.
Okay, so let's unpack this journey. It sounds pretty detailed. We're starting with that essential foundation, right? The anatomy and the, four critical functions of the skin?
The four critical functions. Then we're going to dive deep into the specific terminology for describing lesions. This is the foundational language of dermatology.
You have to speak the language.
You have to speak the language, and you have to clearly distinguish between primary and secondary findings. After that, we dedicate a really crucial segment to modern wound management. We're calling it the moist revolution.
The moist revolution, I like that.
And the principles of topical therapy that go with it. Then we'll get into contrasting the major infectious agents, so bacteria, viruses, and fungi. We'll hit all the key manifestations, especially those that are really relevant to community spread, and detail their management.
Okay.
And finally, we'll tackle those age-specific challenges, so things like diaper dermatitis, eczema, atopic dermatitis, and of course, adolescent acne.
Right.
And we'll wrap up with a really critical review of thermal injury, which includes how to accurately assess total body surface area in children, which is a huge deal.
So the objectives we're targeting are pretty substantial. The goal is that you walk away from this truly prepared. We want you to be able to describe lesion configurations accurately, to compare therapies across those infectious categories.
So knowing, for example, why something like tinea capitis needs a systemic medication and a cream just won't cut it.
Exactly. And also outlining detailed care plans for both diaper dermatitis and AD, formulating a really comprehensive teaching plan for managing adolescent acne, and critically, being able to assess burn wounds based on TBSA and depth. You need to recognize when an intervention has to be escalated. This whole approach is really what dictates safe, effective practice here in Canada.
And that last point is just so vital. I mean, safe practice really hinges on a nurse's ability to identify very subtle changes and then apply the appropriate evidence-based care.
Yeah.
We see this urgency, especially when it comes to modern wound healing protocols, which demand such precision in balancing moisture. And also when we're managing complex community-acquired infections like MRSA.
Which we're going to talk about later.
We are. And as we'll discuss, it has some unique socioeconomic implications in certain Canadian communities that really do impact nursing advocacy and practice.
All right, let's start at the very beginning. The architecture of the skin.
The foundation.
It's the protective covering of the body, and it's composed entirely of these stratified epithelial cells. What I always find fascinating is how the body adapts. So the skin is thickest in the areas that get the most friction, right? Like the palms of your hands and the soles of your feet?
Indeed. And understanding that structure is really about understanding the barriers. The
Yeah.
outer layer, the epidermis, is so highly organized. It has 5 distinct layers, or strata, as we call them.
Okay.
And moving from the outside in, we start with the stratum corneum. That's the thin, horny outermost layer that gives us our primary physical and chemical barrier.
Okay, and then you move deeper through the stratum lucidum, granulosum, and spinsum. Why is it so important for a nurse to remember these deeper layers instead of just thinking, okay, it's the epidermis?
Because it relates directly to function and to vulnerability. The deepest layer, the stratum germinativum, that's where cell reproduction happens.
The growth layer.
The growth layer. It allows for self-repair. And it's also where melanocytes live, which provide pigmentation and darken in response to sunlight. So when we talk about a partial thickness burn, for example, if that germinativum layer is preserved, reepithelialization is possible. If it's destroyed,
You need a graft.
you need a graft. And on the flip side, a child's skin is much thinner than an adult's. So in infancy, that external stratum corneum barrier is just less effective, which makes them highly vulnerable to insensible water loss and chemical absorption.
So, okay, if the epidermis is the protective shield, then the dermis, which is right underneath it, that's really the engine room.
I like that analogy.
It's dense connective tissue packed with those collagenous and elastic fibers that give it structure and, resilience.
Absolutely. The dermis is where all the action is. It's where the vascularity, the sensation, the gland activity, all of it happens. It contains the blood vessels, nerves, lymph vessels, hair follicles, and sweat glands.
Wow.
And this complex structure is what allows the skin to perform its 4 essential foundational functions that, frankly, keep us alive and safe.
So let's clearly define those 4 functions. First, and I would argue maybe the most important in terms of just constant interaction with the world, is sensory input.
That's right. The skin is a massive sensory organ. It is constantly relaying essential information to the cerebral cortex. Pain, temperature, light touch, pressure. A failure in this system, like nerve destruction from a full thickness burn, it just fundamentally impacts a child's ability to detect danger.
Okay, function number 2 is protection. It forms that elastic resistant covering we were talking about.
And this function is really twofold. It's chemical and it's physical. Physically, it prevents trauma and infection. Chemically, it's key for inhibiting excessive water and electrolyte loss.
Which is a huge concern in sick infants.
A massive concern. And it also maintains the crucial acid mantle. This slightly acidic pH on our skin protects the deeper tissue from external irritants and bacterial invasions.
Third function, thermoregulation. The skin manages heat loss through, a few different mechanisms?
Conduction, convection, radiation, and evaporation. And here is where we see a massive difference between pediatric and adult physiology. Evaporation, both as visible sweat and as invisible, insensible water loss, is huge. In infants, that surface area to volume ratio is so high, which means they lose heat far more rapidly than adults do. And their ability to sweat effectively is immature, making them highly susceptible to both hypothermia and hyperthermia.
And the fourth function, which you mentioned is often overlooked, is that it's an essential warning system for danger.
It's the early alert system. By constantly sensing pain, pressure, temperature extremes, the skin sends immediate information to the brain.
And that allows for that rapid withdrawal or some other adaptive behavior.
Exactly.
And we can't forget the appendages, right? Hair, nails, and glands. Hair with its follicle and those little erector pili muscles that give us goosebumps. Nails, which are just these modified layers of hard keratin. But the glands, that's where the age-specific changes really start to kick in.
They really do. The sebaceous glands produce sebum, which lubricates the skin and hair and helps minimize fluid loss. What's so crucial in pediatric nursing is knowing that sebum secretion increases dramatically at puberty.
Why is that?
It's due to rising androgen levels. And this excess sebum, when you combine it with follicular obstruction, is the foundational cause of the most common adolescent skin condition, acne.
That's a perfect setup for talking about dysfunction. When we talk about skin lesions, we have to think about the etiology. They rarely just pop up randomly.
No, they arise from exposure to infectious organisms, toxic chemicals, trauma, hereditary factors, external allergens like, a specific plant oil, or even as a manifestation of a systemic disease like lupus or measles.
Right.
A key principle here is that the skin's response is highly individualized. An irritant that's harmless to one child might trigger a really severe reaction in another.
Which is why taking a good history is so critical. You mentioned that age matters a lot here.
Oh, absolutely. Conditions tend to cluster by age. Infants are much more prone to birthmark malformations and atopic dermatitis, which often presents in the first few months of life.
Okay.
School-age children, you see more infectious diseases like tinea and warts. And then, as we just noted, the onset of puberty brings on characteristic disorders like acne.
If more than half of pediatric dermatological conditions are some form of dermatitis, what's the underlying pathophysiology of that inflammatory response? What's actually happening?
So dermatitis, generally speaking, implies a very specific sequence of inflammatory changes. In an acute response, the body is reacting defensively. We see intercellular and intracellular edema, which leads to swelling. Intradermal vesicles start to form, And inflammatory cells like lymphocytes and macrophages, they infiltrate the epidermis and dermis to fight off whatever the perceived threat is.
And what happens if that condition isn't resolved, if it becomes chronic?
Well, if the underlying irritant or, chronic scratching continues, the skin itself changes. Chronic conditions can lead to lichenification, which is a thickening of the skin, and even permanent scarring or pigment changes.
Wow.
The good news, though, is that those acute changes are usually reversible. Our core nursing goal is to prevent the complications,
Yes.
specifically things like ulceration, aggressive scratching, or a secondary bacterial infection.
Okay, let's shift to the diagnostic evaluation. When we're inspecting a child, what are the first subjective symptoms we need to be capturing? Pruritus is the obvious one, but what else?
Pruritus, or itching, is by far the most common complaint. It's the one that causes the most distress and sleep loss for the child and the family.
Yeah.
Beyond that, the child might report specific abnormal sensations, things like pain, tenderness, burning, prickling, stinging, or even paresthesia.
What's that?
It's that abnormal pins and needles sensation. It's really important to document if these symptoms are constant or intermittent, and if they're aggravated by external factors like heat or friction.
The history taking here sounds like it's a vital piece of detective work. Beyond the standard questions about onset, what are the critical environmental clues we need to be looking for?
We have to know. Was there a relation to ingesting a new food or a new medication? Was there contact with plants, new detergents, insects, or specific chemicals?
Right.
And you can't overlook the intrinsic link between the skin and generalized allergies. We have to ask about a family or personal history of what we call the atopic triad.
Asthma, hay fever.
And specific food allergies, exactly. Because conditions like atopic dermatitis frequently begin in infancy and are so strongly associated with these systemic hypersensitivities.
Now, objectively, before we get to the primary lesions themselves, what are the key findings we have to note and chart? This is what dictates communication between providers.
We look at the overall objective characteristics. So the distribution, is it localized, generalized, symmetric? The size, the arrangement, is it clustered, diffuse, linear? And the morphological characteristics. We need to determine if the cause is extrinsic, so an outside irritant or infectious agent, or if it's intrinsic, like a manifestation of a systemic disease like measles, or an internal medication sensitization reaction.
Okay, before we dive into the really complex lesion terminology, let's lock down 3 foundational general assessment terms. These describe findings that aren't specific lesions, but are a critical part of the picture.
First is erythema. That's the characteristic redness.
Yeah.
It's caused by increased oxygenated blood pooling in the dermal vasculature.
So it's just inflammation causing the blood vessels to dilate.
That's it. Second, ecchymosis, or what we commonly call bruises. These are localized red or purple discolorations that result from the extravasation of blood flow bleeding into the dermis and subcutaneous tissues.
And finally, petechia.
Petechia are like smaller, more dangerous versions of that extravasation. They are tiny, pinpoint, sharp, circumscribed spots in the superficial layers of the epidermis. They often indicate capillary fragility or a platelet or clotting disorder, so they're a big red flag. Mastering these foundational terms ensures that even your general observations are charted accurately and professionally. Okay, this next section is basically our formal language lesson. When we describe a patient's skin, we have to use the correct terminology to avoid any ambiguity.
Right.
And the key concept here is distinguishing between primary lesions, so those that arise directly from the disease process itself, like a vesicle forming because of a virus, and secondary lesions.
Okay. And those are?
Those are modifications that result from outside factors like scratching or from subsequent processes like healing or infection. An accurate description is, it's often 90% of the diagnosis.
I think the best way to master this is probably through comparison and contrast. So let's run through the primary lesions. Let's focus not just on the definition, but on the feel and some common examples. Starting with the 2 foundational flat lesions, macule and patch.
A macule is the standard. It is flat, it's non-palpable, meaning you can't feel it when you run your finger over the skin, and it's circumscribed, measuring less than 1 centimeter in diameter.
Like a freckle.
Exactly like a freckle. It has color, but no substance. And if that color is due to extravasated blood, it won't blanch when you press on it.
Okay, so if that flat, non-palpable area gets bigger than 1 centimeter, it crosses a threshold.
Then it becomes a patch. It's still flat, still non-palpable, but it's irregular in shape and clearly larger than 1 centimeter.
And what are some classic examples?
Vitiligo, those areas lacking pigment, or a large port wine birthmark. The only difference is size.
All right, now we move to elevation. The next step up is the papule.
The papule is our first elevated lesion. It's palpable, it's firm, and it's circumscribed, but it's still small, so less than 1 centimeter. It involves the epidermis and the upper dermis.
So like a common wart.
Common warts or raised pigmented nevi are perfect examples. You can close your eyes and feel that distinct elevation.
And how do we distinguish a papule from a plaque? Because they're both elevated and firm.
This is a perfect example of why that comparison is so necessary. A plaque is essentially a group of papules that have merged or coalesced.
Ah, okay.
So it's elevated, firm, and rough, but crucially, it's superficial and greater than 1 centimeter, and it often has a flat top. It resembles a plateau rising from the skin.
And the best example of that would be?
The lesion seen in psoriasis. It's large and flat top, not dome-shaped like a single large papule would be.
Okay, moving deeper. If a lesion is elevated and palpable, but it originates further down in the dermis, it's a nodule.
A nodule is defined by its depth. It's about 1 to 2 centimeters, elevated, firm, palpable, and it reaches deep into the dermis.
So like a lipoma.
Lipomas, those benign fatty tumors, are classic nodules. You feel it as a mass underneath the skin, not just on the surface.
Then we have the wheal, which is always transient.
A wheal is highly characteristic. It's elevated, and it has an irregular shape that's due to rapid, localized cutaneous edema. It's solid, often a pale pink with a lighter center, and it vanishes quickly.
It's transient.
It's transient. Urticaria, or hives, and common insect bites are the typical presentations. It's caused by a sudden, localized mast cell degranulation.
Now for the fluid-filled lesions. These are crucial for assessing the stages of infectious diseases. Let's start with the smallest, clear fluid pocket, the vesicle.
A vesicle is elevated, superficial, circumscribed, and is filled with serous fluid synostotic fluid. It measures less than 1 centimeter.
So the early lesions of chickenpox.
Exactly. Think of varicella or herpes simplex. And if that fluid-filled sac grows to be larger than 1 centimeter in diameter, it automatically upgrades to Ebola.
What happens when the immune system responds really aggressively and fills that pocket with white blood cells?
That's a pustule. It is elevated and superficial, but critically, it's filled with purulent fluid, so pus. This signals an acute inflammatory response, usually bacterial.
Like impetigo.
Impetigo and acne are the primary examples of pustular lesions.
And finally, the cyst wraps up our list of primary lesions.
A cyst is structurally different. It's elevated and circumscribed, but it is encapsulated beneath the epidermis and it's filled with liquid or some kind of semi-solid material. It often requires a specific surgical intervention rather than just topical therapy.
Okay, so that covers the lesions that arise directly from the disease.
Okay.
Now here's where it gets really interesting, because the secondary lesions tell us about the patient's behavior, scratching, rubbing, and the progression toward healing or chronicity. So let's describe these secondary lesions and the process that creates them.
Let's start with what happens during chronic irritation, which leads to lichenification. This is such a critical sign of atopic dermatitis.
And what is that exactly?
Lichenification is a rough, thickened epidermis where the normal skin markings become accentuated. It results solely from constant rubbing or irritation over time.
And the most common secondary change we see in healing is the crust.
A crust is simply dried serum, blood, or purulent exudate that's left behind after a primary lesion, like a vesicle or pustule, has ruptured and wept.
So it's a scab.
It's the scab that forms over an abrasion or healing eczema. It forms a protective layer.
Scale is also very common, and that's related to cell turnover.
A scale is made of heaped up, abnormal keratinized cells, and it results in flaky exfoliation. They can be thick, thin, dry, or oily. Psoriasis is known for its prominent silvery scales, but you also see them in fungal infections.
If the damage goes deep, the body has to substitute tissue, which leads to a scar.
A scar is thin to thick fibrous tissue that replaces the injured dermis. It's a necessary repair mechanism.
But sometimes it overdoes it.
Exactly. If the body overdoes the collagen production during healing, you get a keloid, an irregularly shaped, elevated scar that extends well beyond the boundaries of the original wound. And keloids are particularly challenging in pediatric and adolescent patients because of the cosmetic concern.
Fissures and excoriations are often related to dryness, injury, or severe scratching.
A fissure is a deep, linear crack or break that extends from the epidermis all the way into the dermis. This is extremely painful because it exposes nerve endings. You see it commonly in severe dryness or conditions like athlete's foot.
And an excoriation.
Excoriation is just the loss of the epidermis resulting from mechanical trauma. So it's typically a linear or crusted area that's caused by an abrasion or a scratch.
Finally, let's differentiate the two forms of tissue loss, erosion and ulceration.
An erosion is superficial tissue loss, just the loss of all or part of the epidermis. It's moist and glistening, and it happens immediately after a vesicle or bulla ruptures.
Like when chickenpox lesions break.
Precisely. An ulcer is much more serious because it represents the loss of both the epidermis and the dermis, making it concave and exudative like a decubitus ulcer.
And that distinction between erosion and ulceration is so critical because an ulcer is almost certainly going to scar, whereas an erosion may not.
Exactly.
So beyond just visual inspection, what are the formal diagnostic techniques that a nurse has to facilitate or explain to a family?
We rely on several tools. There's microscopic examination of skin scrapings to look for fungi or mites, like in scabies. We do cultures of exudates or skin lesions to identify bacteria or viruses. And sometimes a formal biopsy is needed if a systemic or potentially malignant disease is suspected.
And there are others too, right?
Yes. Other key tools include patch testing for allergens and severe contact dermatitis, the wood light examination, which is a black light that makes certain fungal infections fluoresce, and allergic skin testing. These are all essential for confirming the pathology and guiding therapy.
So moving from general lesions to wounds, which are what? Structural or physiological disruptions of the skin that activate the body's repair responses.
That's a perfect definition. We classify them first by duration.
Hmm.
So acute wounds, they heal predictably within 2 to 3 weeks without any complication.
Okay.
Chronic wounds are those that fail to heal within that expected time frame, or they're complicated by factors like a retained foreign body, poor nutrition, or critically infection.
And wound healing can be hampered by other things too.
Oh, always. It's hampered by factors that disrupt the process. Things like compromised perfusion, malnutrition, especially protein and vitamin C deficiency, and, as I said, infection.
And the classification by depth is identical to the burn classification, which we're going to cover in detail later on.
Precisely. They are superficial, partial thickness, which involves only part of the dermis, or full thickness. And full-thickness wounds are the most complex. They involve destruction down to the subcutaneous tissue, muscle, or even bone, and they demand specialized care.
This brings us back to tissue regeneration and that difference between labile and permanent cells. What kind of tissue can regenerate easily?
The epidermis is highly regenerative. Epithelial tissue is composed of what we call labile cells, meaning they are constantly being destroyed and replaced throughout life.
Right.
Therefore, superficial injuries like abrasions that only involve the epidermis can regenerate easily, often without scarring, because that germinativum layer is preserved.
But once the damage extends deep into the dermis, the prognosis for healing changes dramatically.
That's because the deeper tissues, muscle and nerve cells, are permanent cells that are unable to regenerate. So to restore continuity after a deep laceration or a full-thickness burn, the body has to substitute fibrous connective tissue.
And that results in a scar.
This process of substitution is fibrous repair, and it's very distinct from regeneration.
Before we jump into specific wound care, pressure injury assessment is unfortunately a critical component of pediatric care, especially in acute and long-term settings. What factors put children at specific risk beyond just simple immobility?
While immobility is primary, children are often at risk due to very specific factors. Protein malnutrition, severe edema, incontinence, which rapidly compromises the skin barrier, sensory loss from neurological conditions, anemia, and infection. In the pediatric setting, a key difference from adult assessment is that pressure injuries frequently occur on the head.
Oh, interesting. Why?
It's due to prolonged positioning and intubation. Nurses use specialized scales, with the Braden QD, to evaluate injury severity and to guide preventative strategies like turning schedules, moisture management, and nutritional support.
Okay, let's turn to general therapeutic management. What is the overarching primary aim of all dermatological treatment?
The central aim is really fourfold. You want to prevent further damage, eliminate the cause, prevent complications like a secondary infection, and relieve discomfort, particularly pruritus.
And you have to eliminate those environmental contributors.
Absolutely. Specific soaps, bubble baths, tight clothing, or prolonged exposure to wet diapers, all of it has to go.
And here's where we get to the moist revolution, this fundamental shift in wound care philosophy. Why is dry, crusty wound care now considered, obsolete?
The standard of care has fundamentally shifted from promoting a dry environment to promoting a moist, crust-free environment.
And why is that?
Research shows that epithelial cells prefer to migrate across a moist surface. So when a wound is kept moist, epithelial migration and tissue remodeling are dramatically enhanced, collagen synthesis increases, and pain decreases.
You quoted a remarkable statistic in the sources. Can you reiterate that difference in healing time?
It's transformative. An acute full-thickness wound that is kept moist will usually re-epithelialize in about 12 to 15 days.
Okay.
If that same wound is left open to the air to dry out and form a scab, healing takes 25 to 30 days. We literally cut the healing time in half simply by managing moisture.
So moist dressings are the cornerstone. This facilitates a process called autolytic debridement.
Yes, autolytic debridement is the body naturally cleaning the necrotic tissue using its own enzymes and moisture, and that's facilitated by the moist environment we create.
Mm-hmm.
The major nursing challenge here is balance. We have to maintain a moist wound bed to promote healing, but at the same time we have to ensure the surrounding skin, the peri-wound area, stays absolutely dry.
To prevent maceration.
Exactly. To prevent maceration, which is skin breakdown due to excessive moisture. Selecting the right dressing, like a hydrocolloid or a foam, and determining the appropriate change frequency is how we manage that balance.
Let's discuss topical therapy, particularly for comfort and inflammation relief. What's the rule regarding temperature application?
Generally, lukewarm or cool applications offer the greatest relief for itching and irritation, which is usually the chief complaint. The vital nursing alert here is that heat almost always aggravates generalized inflammatory conditions.
Why is that?
It increases blood flow. We reserve heat applications only for specific localized inflammatory processes that need to encourage drainage, like folliculitis or cellulitis.
And the practical choice between an ointment and a cream depends entirely on the goal.
Absolutely. Ointments, having a petrolatum base, are designed to be occlusive and provide a protective barrier against moisture. So they're indicated for areas prone to wetness.
The diaper area.
The diaper area, skin folds, or around gastrostomy tubes. Creams, on the other hand, are water-based. They're less greasy and they absorb into the skin, making them better for non-greasy areas like the face and hands, where a protective barrier is less needed than moisturizing.
Now, for the most frequently used therapy, which requires some strict parental teaching, topical corticosteroid therapy.
Glucocorticoids are potent inhibitors of inflammatory and allergic reactions. But we have to counsel parents and children meticulously. You apply only a thin film and massage it in.
A thin film.
The instruction is often the size of a pea for a large area, and the use must be limited, ideally to no more than 5 to 7 days for an acute flare.
Why so short?
Because prolonged excessive use risks serious local adverse effects, like depigmentation, skin thinning or atrophy, and striae, which are stretch marks. And in chronic widespread use in children, we also have to monitor for systemic absorption and the risk of growth suppression.
What other topical or systemic therapies should we mention that might complement or even substitute for steroids?
We use treatments like chemical cautery, cryosurgery, or laser therapy for specific localized issues like warts or birthmarks. We also see topical immunomodulators like tacrolimus and pimecrolimus.
And those are a big deal.
They're a huge deal. These are non-steroidal treatments that are incredibly valuable for reducing the chronic itching and inflammation of atopic dermatitis, especially on the face, where steroid use is so risky. Systemically, we use tapered dosage corticosteroids, and antibiotics or antifungals are reserved for confirmed, severe, or widespread infections.
In terms of general wound care, let's revisit a critical nursing alert about cleansing solutions. What should parents absolutely not be using at home?
We have to emphatically caution that common household antiseptics, povidone iodine, alcohol, and hydrogen peroxide, are toxic to healing wounds.
Wow.
They kill the fibroblasts and epithelial cells that are vital for tissue repair. The safest and most effective solution for wound cleansing at home is always normal saline or gentle washing with mild soap and water. A forceful jet of saline is often needed to dislodge foreign material rather than just soaking.
And when you're covering wounds, how do we protect that delicate peri-wound skin from the trauma of just repeated tape removal?
For large or chronic wounds that require frequent changes, nurses use strategies like a non-alcohol skin barrier wipe before applying tape or picture framing the wound.
Okay, what's that?
That involves securing the tape only to a protective border of hydrocolloid dressing that's placed on the intact skin. Alternatively, you can use Montgomery straps or stretch netting to secure dressings without any tape at all.
You mentioned a specific nursing alert related to hydrocolloid dressings that can prevent some significant parental anxiety.
Yes, hydrocolloid dressings work by absorbing fluid and forming this yellow, often malodorous gel underneath.
And that looks like?
It can look and smell just like pus. And it causes parents to panic and remove the dressing prematurely, thinking the wound is infected.
Right.
So we have to advise them clearly that this is a normal product of autolytic debridement and absorption and not necessarily a sign of infection.
Finally, puncture wounds are managed very differently from lacerations.
Oh, absolutely. Puncture wounds are dangerous because they are deep, and they often harbor debris or bacteria, especially if they're caused by rusty objects.
So what's the standard instruction?
If a tetanus booster is up to date, the instruction is to soak the wound in warm water and soap for several minutes. Sometimes rebleeding the wound can help flush out debris. However, any puncture of the head, chest, or abdomen, or those where part of the object might remain, they require immediate, careful medical evaluation and sometimes imaging.
And just to tie this back to that subjective complaint, how do we systematically manage pruritus beyond just cool compresses?
Managing the itch is paramount. Scratching is what causes secondary lesions and opens the door to infection. So we advocate for mechanical measures. Soft, lightweight clothing, keeping fingernails short and clean, and using protective coverings like mittens or long-sleeve outfits, especially for small children and during sleep. For severe sleep-disturbing itching, oral antihistamines like the sedating diphenhydramine at night or a non-sedating one like loratadine during the day are essential adjuncts to those topical therapies.
Yeah.
Okay, so when the skin's barrier function is compromised through trauma or dryness or systemic illness, it provides a really easy entry point for pathogenic organisms. And the risk of a serious bacterial infection is highest in children with congenital or acquired immunodeficiency, those who are debilitated, or those who are receiving immunosuppressant therapy.
Let's review the key bacterial disorders from the source material, starting with the iconic impetigo contagioso, which is usually Staphylococcus or Streptococcus.
Impetigo starts pretty benignly as a reddish macule, but it quickly turns vesicular. It ruptures very easily, leaving a moist, raw erosion. Its absolute defining characteristic is that the exudate dries to form these heavy, honey-colored crusts.
And it's highly contagious.
Highly contagious and easily spread by what we call autoinoculation. So the child scratches and then transfers the bacteria to somewhere else on their own body.
The nursing management here sounds meticulous. You have to remove the crust before you can even apply the medication.
Yes, the crusts have to be softened and carefully removed, usually with an agent like 1.2 Gerl-Burrows solution compresses. Only after this debris is cleared can a topical bactericidal ointment be applied effectively.
And for severe cases.
Systemic, oral, or parenteral antibiotics are used for widespread or severe cases. And we have to stress non-sharing of washcloths and towels in the home.
Moving a bit deeper, pyoderma is a step up in severity.
Pyoderma is a deeper bacterial infection that extends into the dermis. And this means the systemic effects are much more likely. So you'll see fever, malaise, and often visible lymphangitis.
And what's that?
That's the red streaking that shows inflammation of the lymph vessels. Management involves rigorous soap and water cleansing, wet compresses, and systemic antibiotics. We have to emphasize that this requires more aggressive, whole-body treatment than superficial impetigo.
Okay, for infections involving the hair follicles, folliculitis, furuncle, and carbuncle, the difference is really just the extent of the inflammation.
That's right. Folliculitis is the simplest infection of a hair follicle. A furuncle, or a boil, is a larger, deeper, red, and swollen lesion involving a single follicle. And then a carbuncle is the most extensive. It's a group of interconnected furuncles with widespread inflammation involving multiple follicular orifices.
Wow.
So management often requires warm, moist compresses to localize the infection, systemic antibiotics, and often incision and drainage IND to release the purulent material. The critical nursing tip here is that families must be emphatically counseled to never squeeze these lesions.
Why not?
Squeezing can push the bacteria deeper into the dermis or even into the bloodstream, which just worsens the infection.
Cellulitis is a really serious, rapidly spreading infection that demands prompt tracking.
It is. Cellulitis is a deep inflammation of the skin and subcutaneous tissues. It causes intense redness, swelling, and firm infiltration. And like pyoderma, you often see that lymphangitis streaking.
And management is aggressive.
Very aggressive. Oral or parenteral antibiotics, rest, and immobilization of the affected limb, plus hot, moist compresses to encourage circulation. The crucial assessment for the nurse is to mark the outer edges of the erythema with a permanent marker upon admission, and then regularly reassess to track whether the infection is spreading or receding.
Because if it's spreading
despite antibiotics, that requires an immediate escalation of care.
and staphylococcal scalded skin syndrome, that sounds like a true pediatric emergency.
It is. It's caused by a toxin-producing S. aureus strain. It starts with macular erythema and a sandpaper texture. Within 48 hours, the epidermis wrinkles and these large, fragile bullae appear, often resembling a partial thickness burn.
And it's dangerous in infants.
Exceptionally dangerous in infants. There's a massive risk of fluid loss, impaired thermoregulation, and a high susceptibility to secondary infection. But reassuringly, it typically heals without scarring because the basal layer of the epidermis is usually spared.
Here's where we transition to a really critical public health and socioeconomic concern, one that's highly relevant to Canadian practice: methicillin-resistant S. aureus, or MRSA.
The concern isn't just hospital-acquired MRSA anymore. We are seeing rising cases of community-acquired MRSA in crowded settings like with athletes, in correctional facilities, and in daycares.
Right.
But what the sources highlight as uniquely critical in the Canadian context is the high rate of virulent skin and soft tissue infections among Indigenous populations.
And the etiology, it goes beyond just simple individual hygiene. It relates directly to housing conditions.
That's exactly right. This increased prevalence is tied to systemic environmental challenges, specifically household overcrowding and a lack of indoor piped water. This environmental context severely impairs the ability to maintain adequate personal and environmental hygiene, and it creates a fertile ground for transmission.
So for nurses,
For nurses, this shifts the focus beyond just immediate lesion care and toward recognizing the role of social determinants of health and engaging in the necessary advocacy for basic health infrastructure.
So, synthesizing the nursing care for all these bacterial infections, what are the three non-negotiable rules for preventing spread and recurrence?
First, mandatory hand hygiene before and after any contact. Second, prevention of self-inoculation. The child must be warned not to touch and scratch the area, and we use physical barriers if necessary. And third, rigorous environmental hygiene in the home. Separate washcloths, towels, and clothing that's changed daily and washed in hot water.
Okay, moving on to viral infections. Viruses are obligate intracellular parasites, right? They use the host cell's machinery to reproduce.
Let's look at warts, or verruca, caused by human papillomavirus.
Warts are gray or brown, elevated firm papules with a roughened, almost filiform surface. Management relies on local destructive therapy, so cryotherapy, freezing salicylic acid, or caustic solutions. The key teaching point, though, is that many warts eventually disappear spontaneously, although the course is unpredictable and often quite lengthy. Nurses will use topical anesthetics like EMLA cream before destructive treatments to minimize pain, especially in children.
Herpes simplex or cold sores, highly recurrent.
It presents as these grouped, burning, itching vesicles on an inflammatory base, typically near the mucocutaneous junctions of the lips or the nose. Management is mostly symptomatic relief, like Burrow solution compresses during the weeping stage.
Can you shorten it? You can. Topical antivirals like penciclover can shorten the duration if they're started early. Oral antivirals are reserved for severe cases. And crucially, preventing recurrence in type I lip blisters often involves using sunscreens that protect against UVA and UVB light.
Varicella zoster, or shingles, this is the same virus as chickenpox resurfacing.
The virus reactivates in the sensory ganglia, and it results in these painful crops of vesicles that are confined strictly to a dermatome,
A dermatome being.
the area innervated by a single spinal nerve. Management is primarily symptomatic, so analgesics, moist compresses, and occasionally systemic acyclovir.
Right.
Reassuringly for parents, the pain is usually minimal in children compared to adults, and the severe postherpetic neuralgia seen in older populations is rare in the pediatric age group.
And molluscum contagiosum, the benign pox virus infection.
This one causes small, flesh-colored papules that are defined by a characteristic central depression, which makes them look umbilicated. In healthy children, they almost always resolve spontaneously within about 18 months. So treatment like curettage or cryotherapy is generally reserved only for lesions that are extremely widespread or troublesome. It's very common in school-aged children.
Finally, the fungal infections, or dermatophytoses, also known as ringworm. These are superficial infections designated by the term tinea.
Fungi invade the keratinized tissues, the stratum corneum, the hair, and the nails. Tinea capitis affects the scalp. It presents as scaly, circumscribed patches of hair loss or alopecia, sometimes with a deep inflammatory reaction called a cheiron.
And it's transmissible.
It is. It's transmitted person to person or animal to person, often from infected pets.
Now, why does tinea capitis require systemic treatment, unlike tinea corporis on the body?
Because the fungus is deep within the hair follicle itself. Topical applications just can't penetrate the site of infection effectively.
So you need oral therapy.
You do. Oral therapy with grisevolvin or ketoconazole is necessary. Selenium sulfide shampoos are used adjunctively to reduce spore shedding and transmission, but they will not cure the infection on their own.
Okay, for tinea corporis body ringworm.
This is the classic presentation you think of. a round or oval erythematous scaling patch that spreads peripherally and tends to clear centrally, creating that ring shape.
Mm-hmm.
Local antifungal applications like clotrimazole or miconazole cream are highly effective here. The nursing instruction is to apply the cream 2.5 centimeters beyond the lesion periphery and to continue the application for 1 to 2 weeks after the lesion appears to have healed to prevent recurrence.
Let's touch on the common fungal infections of the feet and the groin.
Kinea crudis, or jock itch, is localized to the medial proximal thigh and crural fold. It's managed with local antifungal liquids like tolnaphtate. Tinea pedis, or athlete's foot, is most frequent in adolescents. Management there is all about eliminating heat and perspiration.
So clean socks, good shoes.
Clean, light socks, well-ventilated shoes, and antifungal powder.
When parents are administering grisafulvin, you mentioned a crucial piece of teaching for the best absorption.
This is one of those high-yield nursing facts you need to know. Grisafulvin is lipid-soluble. To ensure the best absorption, the medication must be taken with high-fat foods, like milk or fatty meals.
And if you don't?
Failure to do so drastically reduces the drug's effectiveness. We also counsel on possible adverse effects like photosensitivity, so they need sun protection. And we monitor for potential leukopenia, liver, and renal changes if it's used long-term.
And just briefly, what about systemic mycotic infections, the deep fungal diseases?
These are rare, but very serious. They invade the viscera as well as the skin. They're typically acquired by inhalation of spores from the environment, not person-to-person transmission.
What are some examples?
North American blastomycosis and histoplasmosis, which is endemic to the St. Lawrence Valley region. These usually present with granulomatous cutaneous lesions and require aggressive systemic treatment, often with IV amphotericin B.
All right, transitioning now to skin disorders that result from contact, chemical, physical, and animal. Let's start with contact dermatitis. This is an inflammatory reaction to chemical substances, and it requires distinguishing between two types of agents.
Exactly. We have to differentiate between a primary irritant and a sensitizing agent. A primary irritant, like a harsh detergent or feces, will irritate virtually any skin it comes into contact with. It causes immediate damage.
Okay.
A sensitizing agent, on the other hand, like nickel or urushiol oil from poison ivy, only causes a reaction in individuals who have previously encountered it and developed a specific delayed hypersensitivity immune response.
What are the common contact irritants we see in pediatric nursing practice?
In infants, it's often those primary irritants: urine, feces, harsh soaps, bubble baths, or rough, tight clothing. In older children, common sensitizing agents include metals, like nickel in jewelry or snaps, synthetic fabrics, or specific plant oils.
And the location of the lesion is a big clue.
It's often the nurse's first clue. Generalized involvement might suggest a change in laundry detergent or bath soap, while the linear rash on the arms points to plant contact.
Let's focus on that potent sensitizer found in poison ivy, oak, and sumac, urushiol oil.
Urushiol is the highly potent, colorless oil that's found in all parts of those plants. Critically, sensitivity is acquired after 1 or 2 exposures.
So a child might not react the first time.
Exactly, they might not react at all. And the oil can be transferred so easily by pets, clothes, tools, and even smoke from burning brush.
And the pathophysiology is a classic delayed immune response.
The oil penetrates the epidermis and it bonds with the dermal proteins, which initiates a type IV hypersensitivity reaction. The full-blown reaction, that intense redness, swelling, itching, and the characteristic streaked blisters oozing serum, is delayed. It often peaks about 2 days after exposure, and healing takes about 10 to 14 days.
So if exposure happens, what is the immediate, time-sensitive nursing care instruction you give to parents?
Immediate cleansing is mandatory to remove any of the unbound oil. They should cleanse the exposed skin with isopropyl alcohol or vinegar, followed by a shower with soap and warm water.
And you have to be gentle.
Yes, we have to caution them against hard scrubbing or using harsh soaps, as this removes protective skin oils and can actually worsen the inflammation. And here's a massive piece of parent education that reduces anxiety. The lesions do not spread from contact with the blister serum or from scratching. Once the oil has bonded, the reaction is set.
Okay, what about medication reactions? They're seen in the skin more often than in any other organ.
They can range dramatically in severity from a simple urticarial rash all the way to extensive epidermal necrosis like you see in Stevens-Johnson syndrome. Reactions can be due to toxicity, intolerance, or an allergic response. And the onset is also varied. It can be immediate if there was prior sensitivity or delayed, sometimes up to 7 days after the first exposure.
There's a vital nursing alert regarding 4 medications that nurses absolutely have to memorize.
Yes. If a reaction is suspected during an IV infusion, the nurse must immediately stop the specific IV medication, but critically maintain the infusion line with normal saline.
And then get a history.
Secure a thorough history of previous reactions, noting that penicillin and sulfonamides are notoriously frequent offenders. For severe reactions, the child should be wearing a medical identification bracelet.
Now, on to arthropod bites and stings. Most general bites are just treated symptomatically. But which two spiders in Canada demand immediate medical vigilance?
The black widow and the brown recluse. The black widow bite typically causes localized pain that can become generalized, and it's accompanied by severe autonomic effects like sweating and muscle cramps. It often requires antivenoms, muscle relaxants, and analgesics.
And the brown recluse.
The brown recluse bite is concerning because the venom can cause localized tissue necrosis, leading to necrotic ulcers, alongside potential systemic reactions. It often requires antibiotics and corticosteroids.
For hymenopterans, so bees and wasps managing the stinger is key.
If a stinger is present, it has to be removed as quickly as possible, ideally by scraping it out rather than squeezing it, which can inject more venom.
Right.
For children who are known to be hypersensitive, one sting can cause a severe, life-threatening systemic response or anaphylaxis. They must have a medical ID bracelet and an emergency kit that contains epinephrine auto-injectors. And families need recurrent teaching on proper administration and checking those expiration dates.
Ticks are significant because they transmit serious diseases like Lyme disease. What is the proper non-negotiable removal technique?
You must grasp the tick with fine-tipped tweezers as close to the attachment point the skin as possible, and then pull straight up with steady, even pressure.
No twisting.
No twisting or jerking. That can cause the mouthparts to break off and remain embedded. After removal, the area has to be washed with soap and disinfectant, and the tick should be preserved for identification if the child develops a fever or a rash later on.
Let's detail scabies, caused by the Sarcoptes scabiamate. The mechanism of the intense itching is pretty unique.
It is. Scabies is an endemic infestation where the female mite burrows into the stratum corneum, the dead outer layer of skin, to deposit her eggs and feces.
Okay.
The intense itching that characterizes the infestation is not from the mite itself, but it's a delayed sensitization response to the mite, the eggs, and the feces. And that starts 30 to 60 days after the initial contact.
And in infants?
In infants, it often appears as an eczematous eruption, typically found in the interdigital webs, axillary, popliteal, and inguinal areas. The burrows themselves are minute grayish-brown thread-like lines.
Since the symptoms are so delayed, the nursing care must mandate treating all close contacts, regardless of whether they have symptoms or not.
Oh, absolutely. The medication of choice is permethrin 5% cream or elamite. The application instruction is meticulous. It has to be applied from the neck down, covering the entire body, including between the fingers and toes and under the nails.
What about infants?
Infants also need application to the face. It has to remain on the skin for 8 to 14 hours and is then thoroughly removed by bathing.
What do we tell the family about the rash persisting after treatment? This is a point of frequent confusion.
The rash and the itching will not disappear overnight. They will only resolve once the entire stratum corneum that contains the dead mites, eggs, and feces is replaced, which takes about 2 to 3 weeks.
What about the environment?
We have to advise washing all clothes, bedding, and towels that were used in the previous 48 to 72 hours in hot water, or sealing them in airtight plastic bags for 14 days to kill the mites.
Next, pediculosis capitis, or head lice, a persistent parasite in school-age children. Diagnosis hinges entirely on finding the nits.
Diagnosis is the observation of the white eggs, or nits, which are firmly attached to the hair shaft. They're usually clustered in the occipital area, behind the ears, and at the nape of the neck.
And that adherence is key.
That adherence is the key diagnostic difference from dandruff, which just falls off easily. Empty cases are translucent.
Treatment involves pediculicides and also non-chemical methods.
We use permethrin 1%, cream rinse, or pyrethrin products. Again, we have to be cautious if there's a known ragweed allergy. A second treatment is usually advised 7 to 10 days later to kill any newly hatched lice before they can reproduce.
And non-chemically.
Non-chemical control includes the arduous but necessary daily removal of nits with a metal nit comb.
The educational component here is so critical to dispel the stigma that's associated with it.
First, we have to stress that anyone can get lice. It is not related to cleanliness or socioeconomic status. Lice do not jump or fly. They're transmitted via personal items. So we counsel against sharing combs, hats, and scarves.
And application safety.
For applying the pediculicide, the child should lie supine over a sink with a towel over their eyes to prevent chemical conjunctivitis. And this is vital for nurses to know. Current medical policy in Canada does not recommend excluding children with NITs from school or childcare. This practice is medically baseless, and it only serves to perpetuate stigma and social isolation.
Bed bugs, or Simicidae, are an increasing issue in Canada because of travel.
They are. They're small, about 6 millimeters wingless oval insects that are nocturnal feeders. They typically bite exposed skin like the face, neck, and upper body. The bites create these localized itchy red lesions, often appearing linearly in a characteristic group of 3. We call it breakfast, lunch, and dinner.
Right.
They don't transmit infection, but chronic scratching can lead to a secondary bacterial infection. Elimination requires professional intervention, daily vacuuming, washing linens in the hottest water, sealing crevices, and professional pesticide services.
Finally, let's discuss Lyme disease, which is especially relevant in Canada because its incidence is rapidly increasing.
Lyme disease is tick-borne, caused by Borrelia burgdorferi, and the number of reported cases in Canada has dramatically increased. The peak incidence is bimodal, affecting children aged 5 to 9 years and adults aged 55 to 59.
And it presents in stages.
It classically presents in 3 stages. Stage 1, which is 3 to 31 days after the tick bite, is the pathognomonic sign. Erythema migrans, that large circular bullseye rash.
And the importance of prompt treatment is enormous.
Prompt treatment of the erythema migrans with oral antibiotics like amoxicillin for children under 8 or doxycycline for older children for 14 to 21 days is what prevents progression to the severe neurological, cardiac, and musculoskeletal issues that you see in the later stages.
Finally, the prevention guidelines for DEET use. We have to be really specific in pediatrics.
DEET needs has to be used sparingly and only with Health Canada-approved products. Crucially, it is not recommended for children under 6 months of age.
Wow.
We teach parents to wash the treated skin with soap and water after coming indoors to limit absorption. And prevention also relies on careful tick checks of the scalp, neck, armpits, and groin after any outdoor exposure. All right, now we focus on conditions that are really dictated by the developmental stage of the child, starting with diaper dermatitis. The peak incidence is 9 to 12 months, and it's actually more common in formula-fed infants, possibly because of a higher stool pH.
And the pathophysiology is a classic chemical friction burn.
It begins with prolonged contact with wetness and feces. The skin barrier gets compromised by friction. The breakdown of urea in the urine dramatically increases the skin's pH, making it more alkaline, which then activates fecal enzymes, proteases, and lipases that act as potent irritants and cause the dermatitis.
The manifestation and the distribution are key to differentiating simple irritant dermatitis from a secondary candidiasis infection.
Yes, irritant diaper dermatitis is typically seen on the convex surfaces, so the buttocks, the perineum, and the inner thighs. And critically, it spares the inguinal folds, because they're protected from friction.
And if it's yeast.
If the rash is caused by candidiasis or yeast infection, it's beefy red, it may have perianal inflammation, and most importantly, it presents with satellite lesions. Those are small papules that surround the main rash that cross the inguinal fold.
So the nursing care focuses on altering those 3 contributing factors: wetness, friction, and pH.
The family-centered care plan is straightforward, but it demands consistency. Step 1. Keep the skin dry. Use superabsorbent diapers, change them immediately upon soiling. Expose healthy skin to air whenever you can.
And step 2 is protection.
Step 2. Protect the skin. Apply a barrier ointment, zinc oxide, or petrolatum. And a crucial teaching point. Parents should not remove the thick barrier cream completely with every change. They should just wipe the waste and reapply the barrier over the previous layer to prevent friction damage from excessive scrubbing.
And cleansing must be gentle to preserve that acid mantle.
Exactly. Avoid overwashing with perfumed soaps or commercial wipes that contain alcohol or fragrance. Use water and a mild soap for stool or a non-soap cleanser like Cetaphil just for urine.
What about the common misconception that using cornstarch powder promotes yeast growth?
Research has largely debunked that concern, at least under normal diapering conditions. Cornstarch is generally preferred over talc because it cakes less and carries a lower inhalation risk.
And how should they apply it?
Parents should always shake the powder into their hand first, away from the infant's face, and then apply it to the area.
Now to atopic dermatitis, or AD, which is eczema. This is chronic pruritic eczema with a strong hereditary component, often linked to asthma and allergic rhinitis. It is controlled, not cured.
And the distribution varies predictably by age. The infantile form, from 2 to 6 months, is generalized, It focuses on the cheeks, the scalp, and the extensor surfaces.
Okay.
The childhood form, from 2 to 3 years, typically shifts to the flexural areas. The antecubital and popliteal fossae, so the bends of the arms and knees. And the adolescent form persists on the face, hands, and the sides of the neck.
And the appearance changes from acute to chronic inflammation.
The infantile form shows acute erythema, weeping, and crusting. The older forms are characterized by dry, hyperpigmented, and thickened skin, that lichenification, which results from chronic, unrelenting rubbing. But across all forms, the intense, life-disrupting pruritus is the most defining and damaging feature.
The management goals are comprehensive and they're all interconnected.
There are 4 goals. 1. Aggressively hydrate the skin barrier. 2. Relieve the pruritus. 3. Prevent flare-ups by eliminating triggers. And 4. Prevent or control any secondary infection.
Let's focus on that crucial hydration strategy, often called soak and seal.
Hydration involves a tepid bath with a mild or no soap, followed immediately, and this is the key, within 3 minutes of getting out of the water, by the application of an emollient like Aquaphor or Cetaphil.
And that's the seal step.
That's the seal step.
Oh.
It's designed to trap the moisture that was absorbed during the bath, ensuring the skin remains supple. And avoiding bubble baths is mandatory.
What novel physical measures are used for pruritus relief, especially for those who are prone to infection?
Cool, wet compresses are very soothing. For children who are highly susceptible to secondary bacterial infection, modified bleach baths. A small amount of household bleach added to the tub twice weekly can be prescribed.
And why is that?
The mild antiseptic property helps reduce Staphylococcus colonization on the skin surface. We also use sedating oral antihistamines at night and non-sedating ones during the day.
Regarding prescription medications, the role of topical immunomodulators is a real game changer compared to just relying solely on steroids.
Topical steroids have to be used cautiously and briefly because of the risk of side effects like skin atrophy. But topical immunomodulators, tacrolimus and pimecrolimus, are a significant advancement.
Right.
They suppress the inflammatory response without the steroid risk. They're used at the start of a flare-up, and they can be used freely on the face and intertriginous areas without worrying about the significant side effects associated with prolonged topical steroid use.
So what are the absolute critical nursing priorities for AB?
Control the intense pruritus. This prevents the scratch-itch-scratch cycle, which is what creates new lesions and introduces infection. We do this by keeping nails short and clean, using protective coverings, and meticulously eliminating triggers like wool, rough fabrics, heat, and perspiration.
And supporting the family.
Immense family support is needed. We have to provide comprehensive, detailed written instructions for medication application because the chronic itching and sleep disturbance often lead to significant emotional distress.
Okay, switching gears to seborrheic dermatitis, or cradle cap. How is this fundamentally different from AD?
It is not associated with a family history of allergy, which is the defining factor of AD. Seborrheic dermatitis is a chronic, recurrent inflammatory reaction that occurs where sebum production is naturally increased. It's common in infancy, as cradle cap, and in adolescence. The patches are thick, yellowish, scaly, and oily, but they're usually not intensely pruritic.
And the nursing care focuses entirely on the safe removal of those crusts.
Parents often fear damaging the fontanelle area, which we have to address directly. The fontanelle is safe to shampoo. Treatment involves daily shampooing with a mild soap or a specific anti-seborrheic shampoo. The key is allowing time for the crusts to soften with mineral oil or olive oil, and then gently removing them with a fine-tooth comb or a soft brush.
Finally, acne vulgaris, the most common adolescent skin condition, peaking around 16 to 18 years old.
Acne is primarily driven by the increased production of testosterone during puberty, which stimulates the sebaceous glands to enlarge and produce excessive sebum. And we have to underscore the profound psychological impact.
Right.
Even mild acne can lead to severe low self-esteem, depression, social anxiety, and even thoughts of self-harm. Recognizing and addressing this distress is a core nursing responsibility in adolescent care.
Can you review the 4 main contributors to the pathophysiology of acne?
They work synergistically. 1. Increased sebum secretion. 2. Abnormal desquamation or shedding of follicular cells, which obstructs the follicle, that's comedogenesis. 3. The proliferation of Propionibacterium acnes bacteria within that blocked follicle. And 4. The resulting local inflammation, which creates the red papules and pustules.
General management is simple, but it requires consistency.
Gentle cleansing, once or twice a day with a mild cleanser, is sufficient. Antibacterial soaps are largely ineffective. Families should be counseled that there is no confirmed link between diet and acne. But adolescents must strictly avoid oily creams, cosmetics, and hair products that exacerbate follicular obstruction.
Let's detail the critical teaching points for the key topical medications, starting with tretinoin or retin-A.
Tretinoin interrupts follicular keratinization, which targets the microcomedones, the earliest lesions. The application instruction is highly specific to prevent irritation. You apply only a pea-sized dot to the entire face, rub it into the three main areas, and most importantly, wait 20 to 30 minutes after washing to reduce burning.
And sun exposure.
Because it causes significant photosensitivity and blistering, it has to be applied only at night. And daily use of an SPF 15+ sunscreen is mandatory.
Topical benzoyl peroxide is the effective first-line agent for inflammatory acne.
It acts as both an antibacterial and a drying agent. Its key teaching point is that it will bleach sheets and towels, but not the skin. Adolescents should be instructed to gradually increase the strength and frequency to build tolerance and minimize irritation.
Now, for the most potent systemic drug, isotretinoin or Accutane, it's reserved for severe cystic acne and requires extreme regulatory oversight. The nursing alert here is absolutely non-negotiable.
The most significant risk is its profound, devastating teratogenic effects. Health Canada mandates a stringent pregnancy prevention program. This requires written consent, 2 negative pregnancy tests before treatment starts, monthly negative tests throughout treatment, and 1 month after, plus the simultaneous use of 2 reliable forms of birth control throughout the entire regimen.
And nurses have to monitor that.
Nurses must be hypervigilant in monitoring compliance.
Beyond pregnancy prevention, what other adverse effects of isotretinoin require careful monitoring?
Common side effects include extremely dry skin and mucous membranes, nasal irritation, photosensitivity, and arthralgia, which is joint pain. Critically, nurses have to monitor closely for serious psychological adverse effects: depression, aggressive or violent behaviors, and suicidal ideation.
Wow.
The patient also requires periodic monitoring of elevated liver enzymes and cholesterol and triglyceride levels.
The final nursing support for acne involves counseling against mechanical manipulation.
We have to assess the adolescent's emotional distress level and provide clear written instructions. We counsel emphatically against vigorous scrubbing, picking, squeezing, or manual expression of lesions,
Why?
because this ruptures the ductal walls, spreading the contents into the dermis and worsening the inflammation and scarring. Our final and very critical topic is thermal injury, or burns. In the Canadian context, burns remain a significant cause of pediatric hospitalization. The highest risk group is boys and children under 5 years of age.
And why is that?
It's largely due to their thinner skin and the increased time they spend in the home environment, where scalds and contact burns are just so prevalent.
The severity of a burn is determined by multiple factors: intensity, duration, but the classification relies fundamentally on 2 factors.
Severity is based on the percentage of total body surface area, TBSA, burned, and the depth of the injury. For a child in the school age group or younger, a burn of just 10% TBSA can be life-threatening.
Just 10%.
Just 10%. It's due to the fluid shifts and the increased risk of infection if it's not treated correctly and immediately.
And the TBSA assessment has to be handled differently for children than for adults. This isn't just a minor difference in calculation.
This is a point of potential catastrophic error. Children have proportionally larger heads and smaller limbs than adults. Therefore, TBSA must be estimated using specially designed age-related charts that assign different body proportions for different ages, like the Lundbrauter chart.
And if you don't?
If we rely on an adult calculation, like the rule of nines, we are setting that child up for an inaccurate assessment and potentially inadequate fluid resuscitation,
Right.
which, in a large burn, is a life-or-death scenario.
Let's look at the different types of injury, starting with the most common, thermal burns. But let's focus on the unique danger of electrical injuries in young children.
Electrical injuries, often from biting cords or inserting objects into outlets, are so insidious. The current follows the path of least resistance, so fluid, blood vessels, nerves, and it causes deep tissue damage that's far beyond the visible entry and exit wounds. The trauma is often compared to a deep crush injury.
What are the immediate concerns with electrical burns that would mandate hospitalization?
Serious electrical trauma can result in cardiac fibrillation, respiratory collapse, or deep burns to vital organs. The criteria for hospitalization include any history of loss of consciousness or any observed ECG changes, because cardiac monitoring for 24 hours is standard due to the risk of delayed arrhythmias.
Chemical burns also present systemic risks, beyond just the local destruction.
Severity relates to the agent. Is it an acid, an alkali, or an organic compound? and the duration of contact. Beyond the local tissue damage, there is a serious concern for systemic toxicity if the chemical is absorbed, for eye exposure, and for the inhalation of toxic gases that are produced by the chemical reaction.
And the first intervention is,
Immediate copious irrigation is always the first intervention for chemical burns.
finally, the depth of injury, the three-dimensional wound. We have to distinguish between the three main classifications and their healing prognosis.
A burn is defined by the layers that are destroyed. Superficial burns involve only the epidermis, like a mild sunburn. They're red and painful, have no blistering, and they heal spontaneously in 2 to 7 days.
Okay.
Partial thickness burns involve the epidermis and part of the dermis. They are highly painful, they blanch to pressure, and full reepithelialization is possible as long as the deep dermal elements survive.
And the most severe category, full thickness, changes the entire management strategy.
Full thickness, or third degree, involves the complete destruction of the epidermis, dermis, and sometimes the subcutaneous tissues, muscle, or bone. These burns are stiff, waxy white or leathery, and critically, they are initially insensate.
They don't feel pain.
They have little or no pain due to the destruction of the nerve endings. Because the germinativum layer is completely destroyed, reepithelialization is impossible, and these wounds always require surgical excision and grafting for permanent closure. So we have completed a really comprehensive deep dive into the integumentary system. We've covered everything from the stratified epithelial cells of the stratum corneum all the way to complex full-thickness trauma. The essential nursing priorities for you, the practicing maternal child nurse, must center on these 4 takeaways. 1. Master lesion description, macule versus papule versus plaque for accurate reporting. 2. Always prioritize a moist, crust-free environment for wound healing, recognizing that 12 to 15-day healing window it provides. 3. Aggressive hygiene and family education are crucial for limiting the spread of infectious agents, especially in community-acquired cases like MRSA and lice. And 4. Accurate TBSA and depth assessment is paramount for determining burn severity and the necessary intervention. Remember to use those age-related charts to prevent fluid resuscitation errors.
You know, what stands out here is how intensely practical this knowledge is. This isn't just theory, it's the fine motor skill of nursing assessment. Recognizing the difference between a rash that spares the inguinal fold and one that crosses it, knowing the critical application technique for tretinoin, or understanding the difference in repair potential between an erosion and an ulcer, that detailed knowledge is the difference between effective care and, frustrating recurrence for the child and the family.
And if we connect this back to the bigger picture, particularly the high rates of community-acquired MRSA associated with socioeconomic factors like household overcrowding and lack of indoor piped water in some Canadian communities.
Yeah.
This raises a really important question for all of us. How should nursing practice evolve beyond the immediate wound care to actively advocate for environmental and public health changes that support basic health and hygiene for all families, ensuring that we address the root causes of these infections?
That's a profound question.
It is, and it's one that every Canadian nurse must carry forward in their practice.
Thank you so much for joining us for this deep dive into integumentary conditions. We hope this comprehensive review serves you well in your studies and in your practice.